Hello everyone. Welcome to another live session with us on KPJ Damansara Specialist Hospital Facebook. My name is Public Relations and Digital Marketing for KPJ Damansara. So today we have Dr. Raja Badrul Hisham, who is a consultant general, laparoscopic and colorectal surgeon with special interest in bariatric and obesity surgery, right? And Dr. Raja Bad has been a consultant with us for more than 10 years. And currently, he's a director for Advanced Laparoscopy and Diabetes Surgical Center, right? Dr. Raja Bad has also vast experience in laparoscopic surgery, now pursuing a robotic surgery. And early this year, he was in Boston for a course in robotic, right? So I guess without further ado, I'll pass this to Dr. Raja Bad. Yeah.
Thank you very much, Shaz, for the very kind introduction. I need someone to help me with the slides, actually. So, okay, I've been given the task to speak about this particularly interesting subject, which is obesity and blindness. How is it related? So, in that introduction, you were introduced to this word, which is diabesity. It's kind of a new word, and I'm going to be leading towards that particular word and how it is actually related to blindness. So this is where I work, Damansara Specialist Hospital, as you may all be familiar with. That's just a profile picture of myself. I have, by trade, I'm a general laparoscopic and colorectal surgeon, but I have special interest in bariatric surgery, specifically, which is slightly away from the colorectal surgery. However, because I do a lot of advanced laparoscopic cases, and naturally, I kind of gravitate into a more challenging area of surgery, of laparoscopic surgery, which in part is bariatric or obesity surgery. So this is an article which I plucked out from The Star, which was published on 14th of August 2018. An interesting article written by Dr. Milton Lum, who's actually a very prominent doctor who's very much involved in our public health. This was as recent as 2018, so around about 2 years back. And essentially, the main point that he's trying to point out here is the fact that the prevalence of overweight as well as obesity among, by at least, if you're talking about overweight alone, by at least 80.7%. Yeah. And if you're talking about obesity, it has increased by 302%. And this is within a period of less than 20 years. Yeah. So in 1996, the percentage of people, young adults who are obese, who were overweight was 16.6%, whereas young adults who were obese in 1996 constituted about 4.4% of the population. However, that has jumped by 80.7%, 302%. Making it making over and to be about 17.7% of the population. That's an extremely high figures. So coming back to the term that I was trying to introduce, which is diabesity. Essentially, what it means is it's a combination of two words: diabetes as well as obesity. Obesity is very closely related to diabetes, especially type 2 diabetes, and obesity has its own complications. For example, it may lead to hypertension, sleep apnea, joint disease, many other kind of illnesses. But here, principally, we're going to be talking about diabetes because that is the clinical pathway that may lead to one of the feared complications of diabetes, which is blindness. So here's another article that was picked up, that I picked up from the Malay Mail. This was slightly earlier. It was on 31st of October 2016. And as early as that, they were already using this term, diabesity. And the title of the article was "Diabesity, a Waiting Epidemic for Malaysians." So in this particular article, it was also mentioned that the leading single cause of blindness, kidney failure, as loss of toes, feet, or legs. Yeah. So diabesity is that particular leading single cause. The priority is towards prevention, which obviously can help reduce the future socioeconomic costs and the burden of complications. So coming back to the definition of obesity, yeah, earlier I did mention about being overweight as well as being obese. This is taken out from the Kementerian Kesihatan Malaysia. So this is specifically for the Asian populations, and the measurement down there actually refers here. Actually, this one actually refers to my own self. I weigh 73 kilograms. My height is 1.7 meters, and therefore my BMI would be 25.26. Yeah, and if you look at that, I wouldn't call myself a big person, but I would be in not within the desirable weight category, but slightly out of the desirable weight, but not obese. Okay, anything less than 18.5 would be called underweight. Between 18.5 to 24.9 is a desirable weight for Asians. 30 or more is obese. Yeah, and that's just a translation of obesity. You can see how this is really affecting us, because as for myself, I wouldn't consider myself big, but I'm still out of that ideal weight category. This is another study that was done and was published in the British Medical Journal quite recently in 2016. And they were trying to look at the availability and variability in guidelines on patients with diabetic retinopathy. Diabetic retinopathy is a condition of the eye, which is which is associated to those patients who have poorly controlled diabetes, and especially patients with poorly controlled diabetes secondary to obesity. And they were looking at the availability and variability of guidelines on this particular condition as with regard to screening in Asian countries. And if you look at Malaysia here, yeah, we have a big number of patients, big percentage of patients with diabetes, and a significant chunk of those with diabetes has diabetic retinopathy. Yeah, so you can imagine years to come, there will be a lot of these patients who are diabetic and most likely obese, who will be blind because of the diabetic retinopathy. And the study concluded that countries in Asia need to establish a more comprehensive and evidence-based diabetic retinopathy screening guidelines to be more effective in the execution of programs to reduce the incidence of blindness, and therefore improve patient outcomes and reduce the healthcare costs. Yeah. So as of today, we have not yet have any kind of program, any screening program to screen patients who are exposed to diabetic retinopathy. Yeah. The fact that we know that diabetic retinopathy as well as kidney disease is one of the most feared outcome of diabetes. It is abhorrent that we have not yet come to a point where we are screening these patients. Yeah, something's got to be done about this. Just a little bit of information about the natural history of obesity. How does obesity lead to type 2 diabetes? Starting from here, you have obesity, and what you will find in patients who are obese is that they will become more and more insulin resistant. The pancreas is still producing insulin, but their body, because of the increased amount of fat, they become resistant to the insulin, and then they develop metabolic syndrome. Yeah, and that's when problems start to happen, and that's when the onset of diabetes come in. Yeah, so once the patient has been diagnosed with diabetes, as we all know, is a systemic disease. It affects the whole body. Yeah, and one of the few things peculiar about diabetes is the fact that it affects the small blood vessels terribly. Yeah, and hence the complications arise. And these complications can be seen in the eyes in the form of retinopathy, in the kidney in the form of nephropathy, as well as in the peripheral nerve system, which is called neuropathy. Yeah, so the complications arise following the onset of diabetes, and this may take years, and causing problems whereby with retinopathy, it may lead to blindness. With nephropathy, it may lead to kidney failure. And with neuropathy, it may lead to injuries or ulcerations of the lower limbs or even the upper limbs. So these are some of the complications of diabetes, and ultimately it causes disability and ultimately death. So yeah, we all know, for us to get from here to there, yeah, it takes years and years of commitment. And the best way to prevent or even to treat obesity or diabetes is through diet and exercise. Everybody knows that, yeah, and it's very easy to do that. However, myself being a surgeon and being one of the partners in Advanced Laparoscopy and Diabetes Surgical Center in Damansara Specialist, we have a role in as surgeons to help patients who are obese, especially those who are morbidly obese with diabetes especially, and we call these patients as patients who have diabetes. We have a role in providing them an alternative where, should they be struggling to lose weight and to control their diabetes for a long time, then we would actually give them an alternative in the form of surgery. Yeah. So there are two different types of surgery that we do, mainly here, three different types, but most patients end up having either one of the two. Here I've listed down three. One is called the gastric banding. First, the second one is sleeve gastrectomy, and the third one is laparoscopic Roux-en-Y gastric bypass. Gastric banding seems to be falling out of fashion quite recently, a few years back. So we don't do as many gastric banding as we used to. Most patients will actually have the options of choosing between laparoscopic Roux-en-Y gastric bypass or sleeve gastrectomy. This is just a diagrammatic or a picture illustration of what we do with sleeve gastrectomy as well as gastric bypass. In sleeve gastrectomy, which is here, the objective is essentially to make the stomach smaller. Yeah. In other words, converting the stomach from a bulbous structure into a cylindrical structure, thereby restricting the amount of food that would actually go through, and hence ultimately will reduce absorption, reduce consumption and of the patient, and allows us to achieve the objective of weight loss. Yeah. We have done more than 150 cases of sleeve gastrectomy throughout the years, and patients do have good results from this particular type of surgery. The other option is laparoscopic Roux-en-Y gastric bypass, in which my pointer is now. This, as if you may compare between the two, sleeve gastrectomy achieves weight loss by restricting the amount of diet that the patient can have, whereas in laparoscopic Roux-en-Y gastric bypass, it restricts the amount. At the same time, it induces malabsorption, and it induces malabsorption by this bypass, whereby the food that is being taken in by the patient will not actually go through this part, which is the duodenum as well as the distal stomach, and it will go through a bypass. Yeah, so it bypasses this part of the intestine, which could be as long as 100 centimeters away from the junction. Yeah, so in short, it essentially restricts the amount of food that the patient's taking, and also induces malabsorption, and thereby achieving weight loss. So we do these surgeries laparoscopically. What I meant by laparoscopically is we will create holes onto the anterior abdominal wall, and through these holes, instruments as well as camera systems are being introduced to assist us with the surgery. I'm going to be showing you a short little illustration of the video illustration of the surgery, so that you'll be able to understand this a little bit more fully. This is just a picture of how this surgery is undertaken. This would be the camera system. This would be the instruments that go in to the abdominal cavity, and this is one of the staplers that is used to cut or form anastomosis within the organs, within the abdominal cavity. So let's go into the video. This is the best video that I actually got from YouTube. It's fairly simple and easy to follow. So that's just a video illustration of clinical of bypass. Advanced Laparoscopy and Diversity Surgical Center is a center that was actually started a few years back using a template of a center in Florida in America. So we have clinical pathways being given out to patients prior to the surgery, and therefore the patients who are who come in to this program will be empowered in the sense that they will know exactly what to expect from the time that they come into the clinic at the outpatient level to the point that they are discharged from the hospital, with clear objectives. And further along, they will have to be followed up by the surgeons, and they'll be seen by the dietitians, clinical psychologists, as well as the physiotherapists. And they will also have group sessions with those other patients who have undergone surgeries too. So this is just to show you our Advanced Laparoscopy and Diversity Surgical Center in Damansara Specialist Hospital. That's part of the nursing team, physiotherapists, dietitian, anesthetist, and my fellow surgeon, and our clinical psychologist. Yeah, we do have endocrinologists as well as physicians within the team. So patients who are suspected to be having diabetes will actually undergo a rigorous process of history, clinical examination, and investigations before they are recruited into the program to undergo the surgery. Yeah, we ensure and we make sure that the patients will actually benefit from this surgery from the perspective of reducing weight, as well as potentially curing the diabetes, or even if it's not curing the diabetes, but at least keeping it under control. Yeah, but the big potential in actually curing the diabetes. If you are well aware, there are not that many diseases that could actually be cured Most disease requires medication for control, say for example hypertension, but bariatric surgery, diabetes surgery, the ones that I've just explained, has actually the potential to cure diabetes or even high blood pressure. In conclusion, diabetes, or in other words, obesity and diabetes, leads to blindness, amongst other health complications. Malaysians in general are struggling with diabetes, and it is currently a major public health concern. It is best to prevent obesity through diet and exercise. However, surgical options are available for those with morbid obesity and diabetes. Thank you so much for listening. Should there be any questions, I'm happy to answer them as best as I can. You may use the platform to actually ask me. Okay, I have this question coming out from one of the listeners, asking about a most common case. I presume the most common case of blindness leading to diabetes leading to blindness. Well, the most common clinical scenario would be a big person who has been big for quite a number of years, and his weight keeps on piling to the point that one day, within a few years period, maybe at the age of about mid-30s, this particular person develops diabetes. As you may see from the earlier slide, once you develop diabetes, then the cascade is triggered. And one of the complications of diabetes would be diabetic retinopathy, as well as diabetic nephropathy. And diabetic retinopathy refers to eye disease, whereas nephropathy refers to kidney disease. And these complications may not manifest itself in the first instance that the patient has been diagnosed with diabetes or diabetes because the patient is obese, but it will manifest itself once as time goes on, when his diabetes is not well controlled, and if there's no actual active effort to ensure that the diabetes is either cured or well controlled. And therefore, again, coming back to the surgical option, if this patient remains obese without much effort done to actually tackle the issue of obesity, his diabetes is going to be poorly controlled. The option is actually to go for surgery with the objective of reducing weight, to ensure that the patient is no more obese, and either controlling or perhaps curing the diabetes completely. So that's the most common clinical scenario that I can think of that will be relevant in this talk today. Sorry. Yeah, should there be any more questions? We've still got a little bit more time. I'm happy to answer some of the questions that could be thrown across. Okay, should there be any interest in this particular topic, which I'm sure there will be, because as I've explained earlier, Malaysia has a very, very high incidence of obesity as well as diabetes. You can always be in touch with our Facebook platform, ask questions through there, and I'm happy to answer the questions anytime. Or you could always be in touch with any one of our colleagues here from the marketing department, and they would be able to direct the questions to me, in which I would be extremely happy to answer them for you. So thank you very much. And I've been asked by the administrator, by this team, to actually mention about the time of my clinic. My clinic's Monday to Saturdays between 9 a.m. till 5 p.m. And that's the same for the Advanced Laparoscopic and Diabetes Surgical Center. I actually operate two clinics. One is the General Laparoscopic and Colorectal Clinic, which is on the first floor, whereas the other one is the Advanced Laparoscopic and Diabetes Surgical Center, which is on the fifth floor. That particular clinic requires a little bit more space because it involves many different specialties. For example, the clinical dietitian, clinical psychologist, anesthesiologist, and endocrinologists as well as physicians. Oh, there's one last question. Any risk on the procedure, especially specific groups? Yes, of course, there's risk. We're talking about surgery here. And however, as I've mentioned to you, we always go along the way of thinking where we always think about the risk against the benefit. We will only, take up the surgery with you in the event that we consider that the benefits outweigh the risk. Should the risk outweigh the benefit for any various reasons, then we would counsel patients to perhaps think about some other options. So the risk is there, the risk is real, and hence the reason why we have a dedicated center with dedicated teams to look into all that. Yeah, so patients will go through, as I've mentioned earlier, history, clinical examination, as well as investigations, not just by one particular doctor, myself, but a surgical team, which constitutes many different specialists from various specialties to really consider the risk and benefit of undergoing this operation. Another question that has come about, what is the range like for an obese patient to reduce the weight after going through the operation? Okay, this is a very good question, actually. We always look at the excess weight loss, yeah, EWL. Excess weight, to make it easy, yeah, what I'm going to do now is I'm going to give you numbers. Let's say a patient is kilograms, okay? So to start, his ideal weight would be 70, okay? So his excess weight from 120 minus 70 will be 50. What we normally measure would be the excess weight loss after surgery, which means to say if he lose 40 kilos from 120, making his weight now 80, that means his excess weight loss is 40 out of 50, which is 80%. Okay. So in our cohort of patients, in patients with sleeve gastrectomies, we have achieved an excess weight loss of about 90% over a 2-year period. There is a problem with sleeve gastrectomy though, whereby there are quite a significant number of patients who have regained weight after 2 years. Yeah. Whereas in our laparoscopic Roux-en-Y gastric bypass group, we have achieved an excess weight loss of 75%, and this is fairly maintained throughout the years. So on a long-term perspective, it seems as though the laparoscopic Roux-en-Y gastric bypass is manifesting a better outcome for patients in terms of weight loss. Yeah, and I would say in terms of diabetes too. However, as I've mentioned earlier, since these patients will actually go through various specialties for screening in terms of history, clinical examination, and investigations, then the decision on which operation is to be undertaken for the patient will be a collective decision. So the patient will be empowered to be involved in making that decision along with the specialists from various clinical specialties. Thank you very much for that question. Okay, the next question is, what is the youngest age can do this operation? Our youngest patient that has undergone this operation was actually 18 years of age. Clinically, based on the studies that's done elsewhere, you can do this the operation on patients who are obese as above the age of 12. However, we don't usually advise. We wouldn't advise against it, but we don't. We are not promoting that concept, which is to do an operation at school age. since patients at this age undergo many different challenges, and they still have a lot ahead of them, and they still have a lot to think about. And personally, we feel that it would probably be best to wait until the patient is a little bit mature, and for this operation particularly to be done at the age above 18. However, clinically, from a scientific perspective, you can do it. You can do this operation as early as when patient is about 12. But we personally do it only for those patients who are above the age of 18. And our youngest is actually 18 years of age. I've got another question from Kathy. Kathy or Katty. It's written here Katty, so Katty, I pronounce it. The question is, my BMI is 31. Would it be advisable for me to undergo this procedure? Well, we have to look at it from a holistic perspective, Katie, because we got to look at your age. We got to look at whether this obesity or this high BMI situation is affecting you in any way. For example, is it affecting you in terms of you developing diabetes? Is it hypertension, sleep apnea, which is a big problem, a major problem, joint diseases, skin diseases, so or even reflux disease. So we got to look at it from a holistic perspective. If you're interested, you may perhaps come over and see me. I will go through the clinical history and go through the clinical examination and advise you in a more personal manner so that we could actually individualize this particular treatment, whether it's going to be suitable for you or not. I'm waiting for another question. There is one last question coming up. I'm doing this in the National Patient Center, by the way. They've the hospital has built up this area, and they've done it pretty nicely. Yeah, anyone who's interested to come over, drop by, may see this lady next to me, but you can't see them through the computer. Her name is Khalifa. She is one of the 8 persons who are in charge of marketing and publicity, as well, I presume. Yeah, yeah, for international patients. Yeah, they've got a really nice setup here. It's pretty funky. Any other questions? Yeah, I think that's all for now. It's really great. This is my first time doing it on this particular platform. It's pretty strange, but I guess there's a new norm with the COVID-19 in the picture. It's a bit strange because I'm not seeing anyone. I'm just looking at my face, but whereas you guys are actually seeing me, and the response that I'm getting is not kind of in a way it's electronic. It's not personal. Yeah, it's definitely something which everyone says is a new norm, and I guess we're just gonna have to get used to it. Okay, thank you very much. Khalifa just asked me to share the price of our package for this particular type of surgery. Oh, the package that we're having. Oh, apparently she wants to share the package that we're having in terms of these bariatric surgeries. So we have packages for sleeve gastrectomies as well as laparoscopic root-and-wide gastric bypass. I'm not sure how much the cost. If I'm not mistaken, the laparoscopic sleeve gastrectomy will be in the region of about 40,000, whereas laparoscopic root-and-wide gastric bypass will be in the region of about, sorry, sleeve gastrectomy will be 30, laparoscopic root-and-wide gastric bypass will be around about 50,000. Yeah. So should you have any further questions, you can always, as I mentioned earlier, contact one of my colleagues here, and they will be able to direct you to the relevant departments. Thank you so much. Yeah, great to be here. Thank you.